Hello guys and welcome again. So continuing our discussion about diuretics, we already talked about lube and thiazide diuretics, and today we will be discussing potassium sparing diuretics. So as their name implies, they would spare potassium in comparison to lube and thiazide diuretics, which would lose potassium. And in this video, we will talk about the pharmacokinetics, the mechanism of action, the therapeutic uses, the adverse effects, the contraindications of this group of diuretics. So let's start. So first, let's do a quick recap on what we learned thus far in this series. So we learned that the lube diuretics, which work on the thick ascending limb of lubefenily here and here and here and here. And we also learned that the distal convoluted tubule is splitted into a proximal part and a distal part. So proximal DCT, distal convoluted tubule, and a distal convoluted tubule. And we learned that the thiazides would work on the proximal part here and here and here and here. And today the potassium sparing diuretics would work on the distal part here and here and here and here. Now let's mention the types of these diuretics. So potassium sparing diuretics. So we will divide them into steroids and non-steroids potassium sparing diuretics. So steroids and non-steroids. The steroids the famous ones of these steroids are the spironolactone. The trade name for that is aldosterone, so spironolactone, and epilerenone, which is the newer agent. So epilerenone. The non-steroids potassium sparing diuretics, we have the famous trimeterene and the amiloride. The difference between those is that the steroids, which is the spironolactone and the epilerenone, would have an intracellular receptors that work on, and those would have a different mechanism that we will learn in the next slides. So let's mention some of the pharmacokinetics, some of the important points in the pharmacokinetics of these drugs. So we have the spironolactone and the trimeterene, so spironolactone and the trimeterene are metabolized by the liver, so metabolized by the liver in comparison to amiloride, which would be not metabolized, and would go with urine. And would be excreted with urine. Also, another important point is that the spironolactone and the epilerenone would take more than 2 weeks. So spironolactone and epilerenone would take more than 2 weeks until they reach their full effect, until reaching full effect, because those would have an intracellular receptors which already occupied with aldosterone, and those would need to compete with aldosterone, and this would take time until they reach their full potential after 2 weeks. So those are the important points in pharmacokinetics. Now let's explain the mechanism of action. So we already talked about on how the distal convoluted tubule is split into two parts, the proximal distal convoluted tubule and the distal convoluted tubule. In the distal convoluted tubule, we have the water and the sodium are absorbed, so sodium and water are absorbed, and the hydrogen and the potassium are excreted, so hydrogen and potassium, and that's all by the action of aldosterone. So the potassium sparing diuretics, we have the steroids ones, which are the spironolactone and the epilerenone, would compete with the aldosterone for the intracellular receptors, so they would antagonize aldosterone to inhibit this effect. So they would lead to the sodium and water are excreted and the potassium and hydrogen are conserved. In comparison with the trimeterene and amiloride, so trimeterene and amiloride would directly inhibit the sodium channel. So the trimeterene amiloride would directly inhibit the sodium channel. So they would not affect the aldosterone, they would directly inhibit the sodium channel, while the spironolactone and the epilerenone would compete with the aldosterone. And the net result of this effect of the potassium sparing diuretics is that we lose 2 to 5% of sodium and 2 to 5% of water, because salt and water move together, and we conserve the potassium, we retain potassium, and we retain hydrogen. Spironolactone also work by competitively antagonizing androgen receptors too, not only aldosterone but also androgens, because it's a steroid and those are also steroids, so it would have also effect on them, and that would be helpful in treating hyperandrogen in females, because this would have some effect on the females like hirsutism and male pattern baldness, and those would be treated with spironolactone because it would antagonize the effects of the extra androgens circulating in the female blood. So now let's talk about the therapeutic uses of these agents. So they are used in primary hyperaldosteronism, which is known as Crohn's disease. This would cause, primary hyperaldosteronism would cause fluid retention and subsequent edema and hypertension, and also other symptoms, and those are treated with spironolactone and epilerenone, because those would antagonize the extra hyperaldosteronism and they would lead to relieving those symptoms. They also work in secondary hyperaldosteronism, which is associated with heart failure, which is HF, so heart failure, and liver failure, which is LF. In heart failure, we have the heart unable to pump blood enough to the kidneys, so the kidneys would would sense that there is not enough blood coming to them, so they would think that there is not enough blood volume, so they would activate the angiotensin or renin angiotensin aldosterone axis, renin angiotensin aldosterone axis, and this would lead to secondary hyperaldosteronism. And subsequent fluid retention, and already the heart unable to pump, that fluid already exists. What about more fluid going into the circulation from this secondary hyperaldosteronism would lead to these more severe symptoms associated with heart failure. Or also with liver failure, the liver unable to metabolize the aldosterone, which is, as I mentioned before, that it is metabolized in the liver. So if the liver is failed, and it is unable to metabolize aldosterone, this would give us also secondary hyperaldosteronism and subsequent edema, ascites, and another symptoms, and those treated with spironolactone because it would antagonize the effect of the hyperaldosteronism that is circulating in the blood. And it would lead to the relief of the edema and the ascites and the other symptoms present. Now they also work as a treatment for congestive heart failure, but that's in another mechanism because they would enhance the contractility. So enhance contractility and perfusion of the heart muscle in unknown mechanism. And they would lead to better morbidity and mortality associated with heart failure. They also used in conjunction with loop diuretics and thiazides. So we would use either loop or thiazide plus the potassium sparing diuretic, so potassium sparing diuretics, because we would have this would lead to better volume contraction, so better volume contraction, and also this would this would give us better electrolyte balance, better electrolyte balance, because as we know, with the loop and thiazides, we would lose the potassium and we would lose the hydrogen. And with the potassium sparing diuretics, we would spare the potassium and we would spare the hydrogen. So this would give us a better electrolyte if we combine the potassium sparing diuretics with the loop and thiazide diuretics in treatment of heart failure. And this would give us also better volume contraction. Spironolactone also used in polycystic ovary syndrome, and that's because the polycystic ovary syndrome that happens in the females will give us hyperandrogenism, so hyperandrogen, and the spironolactone, and those hyperandrogen would lead to hirsutism, which is hair growing on the legs and the hands or the arms and the chest of the females, which is unusual, and also would give us the male pattern baldness, which will lead to hair falling from the forehead of the females, and that would be treated with spironolactone because it would antagonize the hyperandrogens present in the female blood due to polycystic ovary syndrome. Now let's talk about the adverse effects. So we talked about on how in the distal part of the distal convoluted tubule we absorb the sodium and the water, and we lose the potassium and the hydrogen. And with that exchange is inhibited by the potassium sparing diuretics, we would retain the potassium and the hydrogen, so we might get hyperkalemia, and we also might get metabolic acidosis. And those are famous adverse effects of the potassium sparing diuretics. Now for volume contraction, we would not get that much volume contraction with potassium sparing diuretics because we only have mild diuresis compared to lube and thiazides, so we would not get volume depletion as much as with lube diuretics and thiazides. And we don't get that much hyponatremia too. So those, the hyperkalemia and metabolic acidosis, are some of the adverse effects that more commonly associated with these drugs. Now, spironolactone causes gynecomastia and decreased libido in males. So we talked about how the spironolactone would antagonize the androgens too, so that would antagonize androgens too, and this would be beneficial in females. So beneficial in females because if the females have hyperandrogenism, it would relieve the symptoms of the hyperandrogenism, but it would be not beneficial in males because it would lead to adverse effects. So males would get adverse effects like gynecomastia and decreased libido. Yeah. Now for the contraindications, we talked about on how with the potassium sparing diuretics we get high potassium in the blood, hyperkalemia, and with chronic renal failure, patients already complain or already dealing with hyperkalemia that is associated with the chronic renal failure because their kidney is unable to excrete the extra potassium, and if we give them potassium sparing diuretics, this would lead to the hyperkalemia is even more severe, and this is very dangerous. So it is contraindicated in chronic renal failure. It is also contraindicated with ACE inhibitors because we also get hyperkalemia with the ACE inhibitors, and if we give them potassium sparing diuretics, we would get more severe hyperkalemia, and this is very dangerous too. And that would conclude our lecture today. Thank you guys for watching. Next week we will talk about carbonic anhydrase inhibitors, so stay tuned for that. And please like and subscribe, and see you next week. Peace.